You have to record your recording. Okay. Durgadas sir is unable to join, so he expresses apologies. He will try and join a bit later. So I request Jyotika ma'am to say a few words on behalf of Durgadas sir, and then we will have the lamp lighting and proceed with the webinar.
Thank you, Srimati. I think, thank you, Srimati. This is the 6th webinar of the Clinical Research Committee meet, and which is very ably hierarchy and this thing sort of led by Srimati. We have had very interesting topics the last 5 webinars, and this one also promises to be very good. We have Dr. Sundari and Dr. Anbukani as the judges for this session. Sundari has always been the judge, but Dr. Anbukani will be the outside expert judge for this session. So we have 3 speakers today, Dr. Priyanka, Dr. Shruti, and of course, Dr. Priyamvada. So, and this session is on preventive oncology, mostly based on screening and of course on HPV vaccination. So here it goes. Srimati, start the session.
Arun, can you do the lamp lighting?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. So I think we will proceed with the scientific sessions. Dr. Anbukani, who is our expert, she's just stuck a bit of rains in Coimbatore, which is sort of an untimely rains. So she should hopefully be able to join soon. So with that, I will move on to the CVs and the introduction of the speakers and the judges. Of course, Jyotika ma'am and Sundari ma'am need no introduction.
You can proceed, Srimati.
Please just 1 or 2 words, ma'am. Jyotika ma'am is a senior consultant from Desai Hospital. She's been a teacher for many generations. So she's a great academician and of course a stickler to perfectionism, and she has been behind me at every step of the way. So thank you, Jyotika ma'am. And she is of course won lots of accolades. Sundari ma'am is she's a honorary professor at SMS IMSR.
Leave it, Srimati, leave it.
Ma'am, just 2 words, ma'am. 2 words, ma'am. Of course, Sundari ma'am also needs no introduction, but we know ma'am is a very humble, great teacher, great academician, and it's very nice to have you back with us from US, ma'am. So we're really happy and honored to have you back with us.
Thank you.
Dr. Anbukani Subayan, who's going to be joining shortly. She is a fellowship with gynae oncology. She's a consultant gynae oncologist at Kovai Medical Center, Coimbatore. I will probably reintroduce her just before the expert talk as well when she's joined. She has got lots of accolades to her credit as well. And of course, the 3 speakers who have been selected by their respective society. Dr. Priyamvada from Shimoga. She is a consultant obstetrician and gynecologist at Unity Hospital, Shimoga. And she's been the immediate past secretary of Shimoga as well as past IMA secretary. So we also have Dr. Priyanka Ravikumar from Mysore. She is a consultant OBG at Mediwave IVF Fertility Research Hospital, but her special interests include infertility and also psychosexual medicine and cosmetic gynecology. And she's currently practicing at Brindavan Hospital and Motherhood Hospitals as well in Mysore. Next, we have Shruti Bhavi Patel from Gadak, who's a EC member of the Northwest Kosoga region, and she has got lots of accolades. She has been lots of office bearer jobs. She has had president of IMA Gadak in 2022-23, also of the Gadak Society, and she's also been an investigator for various trials and has won multiple awards. And her special interests include high-risk obstetrics and of course medical education and laparoscopic surgeries. So with that, we will just again sort of go through the do's and don'ts of this webinar. Of course, we have 3 speakers, 12 minutes for each talk, and 3 minutes for question and answers by the judges. As we know, this is a webinar series wherein the 3 best speakers would be awarded at the at the end of the webinar series. So we have had so far most of the societies have participated, and today we have Shimoga, Mysore, and Gadak who are participating. And as ma'am said, the theme of today's webinar is cancer screening and prevention. So may I request the first speaker, ma'am?
Hello.
Yeah, Dr. Priyanka, you ready? You were able to join, sort of do the screen sharing. No?
Your screen, Priyamvada.
I'll share the screen. Just
Yeah. I request, meanwhile, Dr. Priyanka and Dr. Shruti Bhavi to have their presentations ready so that we can then proceed with that. Okay, 12 minutes for the presentation, 3 minutes for the question answers. I will just give you a bit of a hint at the end of 11 minutes so that, you can sort of sum it up, so that we can stick to the time limits.
So if you don't stick to the time and overshoot, what happens is you lose on the question time. So you lose a solid chunk of marks. Okay. So cut the introduction and...
Ma'am, I have not saved the recent one in this iPad actually.
So you want me to share?
Yes, ma'am.
Sure, no problems. Yeah, you can start.
Okay. Good evening, everyone. I'm Dr. Priyamvada. Thank you for the introduction and the chance, ma'am. Today I'll be speaking about screening cancer cervix. Cervical cancer is a major public health problem in women worldwide. It's the second most common gynecological malignancy amongst Indian women after carcinoma breast. Unfortunately, 70% of cervical cancer in India are diagnosed in late stages. Only cancer which can be prevented by vaccine or screening is CA cervix. Hence, screening and prevention become so important. As all of us know that primary screening is by vaccination. Primary prevention is by vaccination and secondary prevention is by screening. Best part of CA cervix is we can detect cancer in pre-invasive stage itself when treatment is possible. It can be done by routine pap smear or cytology. Screening has reduced CA cervix by 70% in developed countries. Next one. This particular infection with HPV has a very long latent period, which makes screening a logical and powerful tool. So, what are the screening methods available? We have cervical cytology that can be done with pap smear and liquid-based cytology, and HPV testing, visual inspection of cervix, and colposcopy. Even though colposcopy is not a screening technique, it can be used for confirmation and management. Coming to the screening guidelines for CIN, we have ACOG, WHO, and FOXI guidelines. Even though all of them are similar with little deviations, we follow FOXI for Indian scenario. According to ACOG, screening has to be started at 21 years of age, and pap smear is done once in 3 years till 30 years of age. After 30 years up to 65 years, it can be done with cytology. If only cytology is done, it is done once in 3 years, and along with HPV, it can be done at every 5 years. Women with HIV infection and immunocompressive condition should be screened annually. Screening can be stopped at 65 years. Women with treatment of CIN 2-3, AS and CA cervix should continue screening for 20 years. And post-hysterectomy, 3-yearly wall smear is done for 20 years if hysterectomy was done for CIN or invasive cancer. What are the FOXI recommendations? In healthcare settings with good resources, screening should begin from age 25 years. In healthcare settings where limited resources are there, screening can be delayed up to 30 years. Periodicity is in healthcare setting with good resources. Women aged 25 to 65 years should undergo CA cervix screening, preferably with primary HPV test or co-testing every 5 years, or with cytology every 3 years. In healthcare settings with limited resources, women aged 30 to 65 years should undergo CA cervix screening with VIA every 5 years, at least 1 to 3 times in their lives. Next slide. And when to stop it? Regardless of resource situation, women should continue to be screened up to 65 years. In women who have undergone hysterectomy for benign reason, screening is not recommended unless there is a history of previous CIN or CIN. In women who have undergone any modality of treatment for CIN 2 plus, screening for 20 years following treatment is mandatory. WHO has outlined certain targets to be met by 2030. There, 90% of girls less than 30 years should be vaccinated. 70% women have to be screened by the age of 35 years and again by 45 years. 90% should receive treatment in both pre-cancer and invasive cancer. Next. Steps of pre-screening counseling. Patient has to be explained and advised properly regarding the screening methods and techniques. How to choose an appropriate screening? The three main screening modalities are HPV testing, cytology, and VIA. Foxy recommends the use of HPV testing as the best method for CA cervix screening alone or in combination with cytology. Let's discuss individually regarding each screening technique. Cervical cytology is the most commonly used screening test for detecting cervical pre-invasive and invasive lesions of cervix. It is important to note that the result of cytology cannot be used for definitive diagnosis, but it can be used for guiding colposcopy and for biopsy. So, procedure, as of all of us know that the prerequisites are patient should be in a post-menstrual phase and abstinence should be followed for 48 hours. No douching or vaginal tampon or intravaginal cream should be applied within 24 to 48 hours. And procedure, patient should be put in dorsal lithotomy position. We have to use bivalve cuspospeculum for complete visualization of the cervix. Devices used are IS wooden spatula, cytobrush, and or broom, plastic broom. Next. The IS spatula is placed on the ectocervix. The cervix is scraped by at least one full circle, and we have to take the whole squamocolumnar junction for the cytology. Cytobrush collects endocervical sample, and cytobrush has to be introduced into the endocervix, and at least last part of the brush should be outside the endocervix. The spatula sample is quickly spread as evenly as possible over 1/2 to 2/3 of glass slide. Endocervical brush is firmly rolled over the remaining area of the slide. The slide is quickly fixed by immersing it in Poplin's jar. Liquid-based cytology. Here, liquid-based medium is used to collect and preserve the cervical cytology cells. Advantages is that it decreases the rate of inadequate cytology, and broom device is used for liquid-based cytology. Here, the plastic broom looks like this in the picture. Here, that longer part will go inside the endocervix, and the shorter part will collect the outer ectocervix cells, and it has to be rotated 5 times. Interpretation for uniform reporting, we are using Bethesda system, and the pap smear appearance in microscopy appears like this. Coming to the HPV testing, HPV is the main causal factor for the development of cervical cancer. 18 HPV subtypes, including HPV 16 and 18, are known to cause invasive cancer. It uses polymerase chain reaction to amplify viral DNA. Backslide. Before one. HPV DNA testing is most effective in women more than 30 years. And nowadays, HPV tests are used for primary screening for cervical cancer after the age of 30 years at an interval of 5 years. Screening of women aged 30 to 65 years with primary HPV testing. Primary HPV testing is acceptable screening method in this age group. Women with negative HPV test should return to the next screening after 5 years. Women with positive test should be triaged either with cytology, HPV genotyping, or VIA, depending on the availability. Co-testing. The combination of HPV testing with cytology raises the sensitivity of a single screening test for high-grade neoplasia, leads to earlier detection and management of HSIL. Screening with co-testing in women aged between 30 to 65 years. Co-testing is the preferred screening method if resources are available. The woman with negative cytology and HPV test should return to routine screening with co-testing after 5 years. The woman with positive cytology and negative HPV test, the follow-up depends on the cytology report. HPV self-sampling. Most of the time, patients they won't come for the test because of hesitation or because of some anxiety. But the self-sampling, it has acceptability is high due to more convenience, less discomfort, and anxiety, ease of procedure. The sensitivity is almost same, that is between 60 to 90%. VIA as primary screening modality. Visual inspection of cervix with acetic acid is promising as a screening tool for low resource settings because it is economical and provides immediate results. Here, 3 to 5% of acetic acid is applied to the cervix and examined after 1 minute. Acetic acid causes dehydration of cervical cells and coagulation of proteins into white precipitates. Positive VIA is defined as presence of well-defined aceto-white area on acetic acid application. Positive VIA is indicative of HSIL and early stage CA. Screening with VIA. It can be used as a screening tool between 30 to 65 years. In limited resource settings, VIA should be done at least 1 to 3 times in a lifetime. Screening via VIA should not exceed the age of, it should not be done beyond 50 years, especially in menopausal women, as transformation zone recedes into endocervical canal and prevents it from being fully visible. 1 minute more. Foxy. Visual inspection we can also do with low-level magnification, also with Lugol's iodine, cervicography, speculoscopy, and spectroscopy methods. Colposcopy, we can add on this test if there is, we have to come to any diagnosis for the biopsy purpose. Foxy recommendation in immunocompromised. In good resource settings, screening should start in first year of diagnosis and every 3 years after that. In limited resource settings, VIA should be done every 3 yearly up to 50 years. Next, screening in pregnancy. Speculum examination at first visit, if normal, defer screening till postpartum period, that is up to 6 weeks. If positive, we have to do as per the screening protocol. Thank you.
Thank you. Ma'am, I will just take a minute to thank Dr. Anbu. She has joined, ma'am. So she joined a bit pretty early. So I think she should be able to join in with the questions as well.
Good, that's very nice. Sundari,
Thank you, Dr. Anbu, for joining. I hope you're all right with the rains and everything. Thank you.
Srimati, thank you for having me. Yes, I have joined and I've actually listened to the rest. Hi, ma'am.
Long time. How are you?
Very well, thank
It's
you.
really nice to hear.
Thank you, ma'am.
Thank you.
Ma'am.
Okay.
ma'am,
Priyamvada,
questions,
yes, it was a good presentation, but I think you would have gone a little more into the details of, See, one thing is I wanted to know there are so many screening tests I've evolved. We used to think that PAP is the best. Okay, for many, many decades, it was gold standard. Why do you think we are getting into so many things? And I wish you could have talked about few more things, molecular biomarkers and other biomarkers in the screening.
In 12 minutes, I finished, ma'am. I had to concise the whole thing to.
Okay. Okay. One thing, see, you said that HPV positive.
Yes,
And a
ma'am.
PAP, you have done co-testing, you have done PAP is negative. Now, how will you proceed with her?
PAP is negative and HPV is positive.
Positive.
We can do HPV genotyping, ma'am. If
Mm.
16 and 18 are positive, then we have to do biopsy under colposcopy guidance. Then we can decide on further management, ma'am.
Okay, that's good. What is the latest recommendation by WHO minimum what we could do for the screening cervical cancer?
HPV testing, co-testing is recommended, ma'am. HPV along with cytology.
In India, are we able to do HPV or a co-testing for all women?
No, in a good resource area, at least we can do HPV testing.
In our India, if you take our this one now situation, what is that WHO has recommended for us?
About
Pap-
recommendation.
cytology only, ma'am.
Hmm?
Cytology.
At least two.
Pap
One is
smear.
at 35, one is at 45. Okay, thank you.
Anbu, would you like to ask her?
So, Priyamvada, there is marks for how much you analyzed your evidence,
Ma'am,
right?
ma'am.
One of the things that we want to see, you are now speaking as an expert speaker, which means that I understand that you've gone through some of the evidence that's being published in terms of screening for cervical cancer. So, if you had to do one test, regardless of the socioeconomic background of the patient, which gives the maximum protection for the patient, what is that one single test that you will do? And where is that evidence from?
HPV testing, ma'am.
And where is that evidence coming from? Any idea? This is going to be like extra marks for you.
Evidence means guideline WHO.
WHO says it divides it into multiple resource settings. It gives you, if you look at all the guidelines, actually, ultimately, all the tests are recommended in some manner or the other, right? So you as a clinician have the autonomy to decide what is best for your patient at that particular point of time in that particular clinical situation, right? But if you had all the resources in the world and if you had to do one particular test, you will do HPV. Right? I'm assuming you have the lab facilities, it's validated, and you have a good test kit. So why is that? Where is that evidence coming from? It'll be good to know this because then we get convinced as clinicians to do the test.
I'm not sure, but maybe from American Oncology Group.
So the evidence actually comes from India, where Dr. Rangasamy Shankaranarayanan conducted a multi-centric 4-arm trial with no screening, VIA, HPV, and pap smear. It was published in NEJM. And following that is when the American Cancer Society changed its guidelines and said HPV is the high performance test that should be performed in good resource settings. And the reason is that they did only one test. They followed up the patients for 8 years. And HPV is the one test compared to pap smear or VIA, which gives lifelong protection for a patient and reduces cervical cancer morbidity and mortality compared to any other test. So if you had the opportunity to do one test at least once in a lifetime for a patient, it comes from this Indian trial. So we need to know that it comes from Maharashtra, from Barsi, and overnight the American Society of Clinical Oncology changed its recommendations, following which Foxy changed its recommendations.
Srimati?
Thank you.
I think I skipped my questions because we have overshot.
Yes, ma'am. Yes, ma'am. Sorry.
Yeah, I know. Doesn't matter. Let's go to the second speaker.
Yeah. Doctor, yeah. I think you have to go to the your PPT.
Make it a slide share. So
Yeah, yeah, ma'am.
I think you have to close that other window which has come, no?
Yeah.
Remind me if you put that, then it will be able to do it.
Yes. Yes.
Yeah.
Yeah, ma'am.
Yeah. Can she start, ma'am?
Yeah, of course.
Yeah, you can go.
Yeah, good evening, everybody. Respected judges and all the KASOGA members. Thank you, KASOGA team and Clinical Research Committee for giving me this wonderful opportunity. I'm Dr. Shruti Patil and I'll be speaking on HPV vaccination. Like, as clinicians, we encounter frequent queries from our patients, whether why to vaccinate, whom to vaccinate, when to vaccinate, what is the dose, which type of vaccine, single, multiple, so on and so on and so forth. So these are the different queries which we encounter. Like all of us know, cervical cancer is a burden on India, along with the other cofactors. Human papilloma virus is the main causative agent. The persistent HPV infection leads to dysplasia in the cells, and it will cause precancerous lesions and leading to cervical intraepithelial neoplasia. And this will go on for 10 to 20 years. There is a long latency period. Finally, it has to become a invasive cancer. So most of the patients infection regress within 1 to 2 years, and many of them will be asymptomatic. But those with persistent HPV infections will progress to invasive carcinoma. So coming to the virus per se, it's a papillomaviridae family, non-enveloped and a double-stranded DNA virus, and it has many types of both high risk as well as low risk. So the oncogenic types have been identified as type 16, 18, 31, 33, 35, and so on. So the 16 HPV, 16 is being the most oncogenic. And together 16 and 18 are responsible for about 71% of the cancers globally. So the that is the World Health Assembly in 2020 has formulated a global strategy, and it has come out with recommendations which include the interventions across the lifetime. And the interventions are not only the vaccination, but it is primary prevention, secondary prevention, and tertiary prevention. Human papilloma vaccine is the one of the intervention which is recommended as a part of primary prevention. So what is the rationale behind introduction of this vaccine as a global strategy to eliminate the public health problem of CA cervix is, as we know, the cancer kills one woman every 8 minutes in the country. And the global analysis says vaccinating pre-adolescent girls is a cost-effective strategy, especially in low research settings. And this is the best buy for preventing this non-communicable disease. So it envisions a threshold of at least 4 cases per 1,000 women for its elimination as a public health problem. And like my previous colleague, Dr. Priyambada, mentioned, it has set a target of 90, 70, 90 to completely eliminate cervical cancer by the year 2030. So this is nothing but a life course approach at all the levels of preventions, the primary, secondary, and tertiary. So we can see here in the graph, so the infection is controlled, prevented at the primary level. So that is the primary prevention. So the vaccination has to be given to the pre-adolescent girls at the age of 9 to 14 years, along with the other preventive measures of sex education, health information in the form of community outreach programs. And then the secondary prevention, which is which is the screening approach at more than 30 years of age and 45 years. And then coming to the tertiary prevention, where we identify the deceased, that is those having the invasive carcinoma, and treat them with either surgery, radiotherapy, whatever is appropriate. So the primary objective is to vaccinate 90% of the girls by age 15 by 2030. And WHO says all the human papilloma virus vaccines, which are identified either bivalent, quadrivalent, nonavalent, are safe and effective. And ultimately, the impact would be, it would prevent 60 million cases and 45 million deaths in 100 years. So these are the vaccines available globally, manufactured by various companies. The Servavac is the manufactured by Serum Institute of India. It is a quadrivalent vaccine which acts on HPV type 6, 11, 18, and 16. So, as I told you, 16 and 18 cause 70% of the cervical cancer. So, all these licensed vaccine offer direct protection for 70 to 80% of the cervical cancer caused by 16, 18. And they also provide cross protection in 13% of the cases. And the direct protection is with the other HPV types is seen in the nonavalent vaccine. So the human papilloma vaccines worldwide have a good safety profile and high coverage. So these are the countries which have included the vaccination in their national immunization program. You can see the green in the map. You can see the green shaded area countries, that is America, Canada, Australia. So and few of the African European countries have already included this into their universal immunization program. So do we have to integrate this vaccine with other? Yes, of course, primary prevention, like I mentioned before, it has to be integrated with other screening, other preventive measures. It could be integrated with so many adolescent health programs when we go to the schools. But we should not delay the vaccination because of these programs. And it is also not necessary to screen for human papilloma virus before we vaccinated. And one more thing which we need to remember and tell the patients is this vaccination does not substitute or eliminate screening. Even if the girls have been vaccinated, they need to undergo the screening as per the standard guidelines. So, like I told, again, this vaccine strategy have to be delivered on the various platforms. It could be school-based activity and the facility health centers, or in the form of outreach programs or health campaigns. And it also depends on the particular country where this is happening, which has to match their health system, delivering infrastructure, cold chain capacity. And along with the routine vaccination, catch-up vaccination is also undertaken to vaccinate all the missed out girls between the age from 9 to 18 years, so that it speeds up the impact and builds up the herd immunity. So these are the countries which show what approach they are taking for vaccination. Some are taking the facility-based approach, and most of them, the blue shaded countries, they are taking up the school-based approach. So, like they have set two targets. So the primary targets are the priority. So these are the targets who are the adolescent girls aged 9 to 14 years. And ideally, we have to vaccinate before they become sexually active. This will ensure a high coverage of over 80% and will reduce the HPV infection. The secondary targets populations being the girls aged more than 15 years, boys, and the older males or the males having sex with males. So these are the secondary targeted, and it is on the priority of the country. If their resources are cost effective for this vaccine, this target population, they can do this. So the schedule. So it is widely 2-dose schedule is recommended for ages 9 and above, 9 to 14. It is spaced at least 6 months apart. Ideally, it is 12 months. This thing, because of the antigenicity, the avidity remains for 12 months and then it stabilizes. But right now we are practicing 6 months. There is no maximum gap between the doses. It can also be up to 3 to 5 years. And also there is a off-label recommendation, that is the single dose schedule. It can be used for ages 9 to 20, and it also offers similar protection and is more affordable, easier to deliver, and also has a good coverage. So the vaccination in immunocompromised is again ideally 3 doses if possible, or else it is just 2 regular HPV vaccine doses 6 months apart, regardless of age or antiretroviral therapy status. So what choice of vaccine? So which vaccine has to be opted? So currently all the licensed vaccines, either bivalent, quadrivalent, nonavalent, are having and offering comparable immunogenicity, efficacy, effectiveness against cervical precancer and cancer, mainly caused by 16 and 18. So they are covering around 70% of the HPV positive organisms, which are mainly 16 and 18. So some special groups, like I told, immunocompromised individuals or children who have experienced sexual contact are the priority groups, and these have to be are at higher risk for encountering the HPV infection, and that's why they have to be priorities for vaccination. However, there is no increased risk for travelers or health workers with HPV, and they can follow the routine vaccination schedule. Now, whether we can vaccinate this along with the other vaccines? Yes, it can be. HPV vaccine can be given along with other live or non-live vaccine, but at a different injection site. And we can consider it giving along with a booster dose of tetanus diphtheria, so that we can avoid the missed shots. Can we use the same vaccine? Yes, ideally, if the same vaccine is used for all doses, it is better. But however, if the patient has forgotten or what vaccine she has taken, what brand she has taken previously, or if that is unavailable at the second dose, they can use another vaccine, and the schedule has to be completed.
1 minute more.
Yes, ma'am. So the coming to the immunology, like I told, it is highly efficacious. All the strains, so the vaccines are efficacious, and the route of administration is intramuscular, and it will create a pro-inflammatory milieu and strong humoral response with a robust memory. And this vaccination will have a 1 to 4 logs higher immune response than the natural. And the antibody levels will peak at 4 weeks, then settle at 12 to 18 months before they stabilize. Many trials have been conducted with single dose, 2 dose, 3 dose, and they have found out that even the single and double dose vaccination is non-inferior to 3 dose. So the safety profile, according to Global Advisory Committee, it is safe, and there are no serious safety issues. So not recommended during pregnancy, but if pregnancy occurs, there is no need to terminate pregnancy, and we can delay the subsequent dose after she delivers. So HPV vaccine is a cost effective and is the best buy for preventing non-communicable diseases. So these are the recommendations. It is recommending the universal national guidelines have said to include it in the universal immunization program, and also the strategic advisory group has told single dose offers good protection comparably. Thank you, ma'am.
Ma'am, only 1 minute for 1 minute down, ma'am. So 2 minutes for Q&A.
How many? She has 2 minutes for discussion. Okay, fine. Shruti, what are the contraindications for
Yes, ma'am.
HPV vaccination? Are there any?
Ma'am, contraindications like any other vaccine, if they are having any active infection, fever, or then we can delay the vaccination for the time being. Otherwise, there are no as such contraindications.
There are 2 contraindications. One, of course, is pregnancy, which you mentioned.
Yeah, I mentioned the pregnancy patient.
The other one is
Yeah.
these vaccines are made with Saccharomyces cerevisiae, which is a yeast preparation. So those known allergy to yeast should avoid these vaccines. So, I mean, it's not common in our country, but you should know what's happening abroad too. Okay, fine. Anbu, please.
Is there a concept of herd immunity in this vaccine, Shruti?
Yeah, ma'am. Like multi-age cohort immunization is also done in case if the girls will not turn up between the 9 to 14 years, what is scheduled, we again give a catch-up immunization to immunize all the missed out girls, so that the impact will be speeded and the outcome will be better. So in the 4-week strategy, the catch-up immunization schedule is also included to immunize the girls which we have missed out.
So that you're talking about is catch-up vaccination. I'm asking about herd immunity because you vaccinate some women, do other women also get protection? I said that's a very
No, no,
common
no,
thing.
no.
Okay.
The catch-up is usually between 14 and 26. So you cannot sub
Yes.
both the issues. Okay, Sundari?
Shruti, it was a good presentation, but anyway, vast, so you can't cover everything. You said the single dose. It is out of SAGE, and out of which study the SAGE recommendation has come as a single dose?
Same IRHH.
Study.
Okay, it's again from India.
Actually,
Be
in
proud
India
about
also
it.
there was one study in Bhatinda and Mansa, ma'am. So they have done a pilot study there, and I think from there, if I'm
No, it's not.
not sure.
It is from again
Yeah.
India. Okay,
Yes,
Dr.
ma'am.
Shankar Narayan and Dr. Partha Basu have given, then only WHO has taken it, and the SAGE has recommended now as the single dose. It's from Indian study by these two. Okay.
Yes.
How it happened, I think all of you know, when there was a vaccine, some deaths occurred in Andhra and some other place. So they took the vaccine was ICMR had stopped the vaccine because Ramaya was one of the centers where we were doing study. It was stopped. Then these people have taken all those girls who had not completed 3 doses. 1 dose, 2 doses, 3 doses they had. They've taken and studied them for many years and then see the antibody titers that are surprisingly was same in all of them. Then Dr. Shankar Narayan and Dr. Partha Basu from this one, and then they recommended the single dose, and WHO has accepted it, and then now SAGE recommends that single dose. Okay.
And
Okay.
thank you.
Thank
Thank you, Dr. Shruti. Can you stop sharing screen?
Yes.
Sorry, Srimati, my score sheet says Dr. Rashmi Patil.
No, I think there was an issue. I think I sent
His
the
old one.
yeah, Dr. Shruti. Thank you, Dr. Shruti, for actually standing in at the last minute. Sorry, this is Dr. Shruti Bavi instead of
Yeah. Thank you, ma'am. Actually, there was less time for me to prepare.
yeah, thank
Yeah,
you.
yeah.
Okay, thank you.
Yeah. So, so sorry, Anbu, I think the other
Yeah, that's all right. I've just changed.
Yeah, thank you. Dr. Priyanka, are you able to screen share?
Yes. First of all, thank you, Kasoga. Thank you, Mox, for giving me this opportunity. And thank you, Srimati ma'am, for being very encouraging throughout. So, can you see the slides? Because I'm not able to
Not
view
yet.
both.
Not yet.
Not yet, not
Not
yet.
yet.
Not here.
Not yet.
Yeah, now?
Yeah.
Yes, ma. Go ahead.
Okay. I'll dive into the topic because I only have 12 minutes. Oh. Okay, for some reason, I'm not able to. Oh.
Okay, otherwise you just move on this way one.
Yeah,
Okay,
yeah,
move on,
I'll
ma'am.
just move on. Okay, okay. Thank you.
Stand.
So, as we know, the second leading cause of cancer-related deaths in women, and stage 4 is mostly palliative. Therefore, the need for decreasing the morbidity and mortality, we need screening to be done. Now, I've divided my topic into how we categorize high-risk individuals, then what is the when to screen them for average risk and high risk, and which method and which is advantageous. And we are more concentrated on the lobules and the ducts. So the high risk factors being your BRCA1, BRCA2, family history of first degree relatives, personal history of having an atypical hyperplasia or lobular carcinoma in situ, radiation therapy anywhere between 10 to 30 years when she's exposed either, or even abdominal radiation which overlaps with the breast is also there into this. Early periods less than 12 years, late menopause more than age of 55, late pregnancy more than 30 years, hormone HRT, alcohol, lifestyle changes like alcohol consumption, lack of physical activity, obesity. High risk classification, the estimated lifetime risk, if it's more than 20% of developing breast cancer, then it's grouped into high risk category. So there are a lot of assessment models which are available. The most common is GALE or NCI model, where the 5-year relative risk of more than 1.6 6-7% are classified into high risk. Here, the age at menarche, then the age of first childbirth, the first degree family relatives, if there's any atypical hyperplasia, all this is considered. Whereas the Tyrrell's, it's the most commonly used is Gale, whereas that Tyrrell-Cusick model is more comprehensive because it involves second degree family relatives also. So these are the other three which is there. Moving on to ACR recommendations, this is the recent 2023 guidelines. It says for high risk individuals with genetic mutations, so start annual MRI between 25 to 30 years, and above the age of 40 years, start the mammography. Then calculated lifetime risk of more than 20%. Again, age of 30, you start annual MRI and then move to annual mammogram. And if there is any abdominal radiation, overlapping breast or even chest radiations, either at age of 25 or 8 years after the treatment, whichever is later, then both annual mammogram and MRI is recommended. And if there's a previous history of the patient developing cancer before the age of 40, then annual MRI and the mammogram. So atypical hyperplasia or lobular carcinoma in situ, again, it's annual MRI. If there's no other risk factors, then even annual mammogram. Dense breast tissue, ultrasound also can be taken into consideration along with MRI if less than 40, if more than 40 years, mammogram and annual MRI. See, when they've recommended annual MRI and mammogram together, usually it's spaced between 6 months so that patient is also comfortable. So they do mammogram after the age of 40, and then after 6 months, you can call her for MRI. This was about high-risk patients. American Cancer Society screening recommendations, again of 2023. They say women between 45 to 54 undergo annual screening. 55 onwards is the biannual screening. Women 40 to 44 have an option to start screening, but 40 to 49 or 70 year and above, breast MRI also can be an important tool. The similar ACOG recommendations, 19 and older, it's the annual breast awareness and clinical examination, 40 to 75 every 1 to 2 years. Above age of 55, it is recommended biannual screening after the up to age of 75. After 75, if you still want to continue screening, it's either dependent on her health status, life expectancy, and the discussion with the patient. The WHO recommends a mammography as a population-based screening method, but they usually suggest 50 to 69 and 40 to 49 and 70 to 75 are kind of left out of the thing. So what is the screening take-home message would be that anything less than 40, ultrasound or MRI, more than 40, that's a mammogram, and each modality I'll be discussing further. So we'll dive into more depth there. But now what we have to understand is we have to inform them. A shared decision-making process should be there about the benefits, harms of screening, annual versus biannual and everything. If you want to continue screening more than 75 years, again, life expectancy, health status, then informed decision process and everything should be there. So this is about the screening take-home messages. Contraindications for screening, either if they have less life expectancy, if they're already symptomatic, whether skin changes, nipple discharge and breast mass and everything, or they're breast cancer survivors with partial mastectomy and everything, it'll be in more diagnostic form that MRI is used for as a method to continue the screening. So diving into mammogram, it's a low dose X-ray because as you see in the picture, there's a compression of the breast tissue there in mammogram between the two plates. Because we achieve a good compression, there'll be low dose of X-ray because breast is sensitive, radiation sensitive, and it's a popular population-based screening method. You can detect microcalcification. Mammogram is highly specific, whereas the sensitivity is relatively good, but not as good as MRI. So the specificity is very good. There's 3D mammography where different images are taken from all the angles. So it kind of gives us a more accurate, but 2D mammogram is what is commonly used in India. And I think it's giving us good results with whatever it is. BIRATS is this evaluation and reporting data service systems. This BIRATS, I'll be taking it up a little later in the next few slides. Around 1 to 2% of mammograms only come abnormal. And in that, 80% are almost biopsied as benign. So there's no absolute contraindication as pregnancy, breastfeeding, or women less than 40. We don't recommend it just before cycles or just during the cycles. The breast is kind of sensitive, so kind of avoid during that time. So this understanding this composition of the breast is very important, because composition A, the breast is entirely fatty, and composition B, there's very scattered areas of fibroglandular tissue. These are the two things which in mammogram you will get a good result. Whereas composition C, which is heterogeneously dense, and composition D, which is fully dense, it's more towards MRI as a screening modality for dense breast tissues. This is again a fibroadenolipoma. There's a popcorn appearance, but well demarcated. Whereas this is more speculated margins, and there's a retraction of the nipple also, which is very evidently seen. It's BIRATS 5, which goes in favor of a ductal, which was proved as ductal carcinoma. And this also is the similar picture. This is all typically benign calcifications and lesions. This is the BIRATS system. So BIRATS 0, you need to just chart down their imaging screening modality and follow up. BIRATS 1, routine screening should be continued, whereas BIRATS 2 is mostly benign, but routine screening is continued. BIRATS 3, check after again 6 months, and then continue the screening. BIRATS 4 is also mostly benign, whereas 5 and 6 goes in favor of malignancy. So biopsy, and 6 goes in favor of treatment. This is the ultrasound breast. You see the skin, fatty, glandular tissue. This is how it looks in the ultrasound. This is a normal ultrasound. Coming to differential this thing, the cyst is anechoic. There's posterior enhancement when you see in the ultrasound. This is more operator dependent, because mammogram anyone can read, but ultrasound an expert is needed in the field, and the expertise operator dependent. Fibroadenoma, it is more hypoechoic, and there is minimal posterior enhancement. Cancer, it's more the margins are very irregular, speculated margins, and there is posterior shadowing to some extent. And the glandular tissue is more hyperechoic, and there's no posterior enhancement or shadowing. Coming to MRI breast, as I said, composition of breast C and D is more sensitive. It's screening for high-risk patients. Then silicone implants and other breast implants, that time we choose MRI over other methods. And neoangiogenesis of the malignant cells serves as a basis for MR imaging. So in MRI, the breasts are placed in the cup, and the patient has to lie down still in this position for around 20 to 30 minutes. So when you see the typically benign lesions are very well defined, and the cyst is an enhancing mass, but very clear margins are seen, whereas an enhancing mass with irregular shape, and this was proven to be angiosarcoma. And this is again a very speculated margin, and the picture of the tissue in real, it's almost very sensitive, so it's a good image of that. Now coming to thermal scanning. Thermal scanning uses heat patterns on the breast, as cancer cells produces more heat due to increased blood flow. It's non-invasive, radiation-free, pain-free, and for mass screening, because it is available even on the mobile, and it's just an app which you have to download. So population-based mass screening programs, when the hospital organizes or anyone organizes, usually, or NGOs and other things, they use this. But just because the screening has detected something in thermal scanning is not absolute, but then they have to be subjected to mammography for further recommendations. And say now the screening is this is how the abnormal tissue appears on the thermal scanning. So before I kind of conclude, one more point would be that some breasts are lumpy. So, and the mammogram comes normal. You've kind of ruled out everything and it's all normal. You need to make the woman understand that this lumpiness is the normal, and any deviation more from that would kind of point towards abnormality, and she has to report back immediately. Thank you. Thank you.
That was an excellent presentation, Priyanka.
Thank you, ma'am.
How much of time do we have, Srimati? 3 minutes.
Yeah, you should.
I just want to mention that you said Virat's 4 is mostly benign. It is
Ma'am,
not.
it's like in between borderline, like benign to malignancy. And
it is
I'll go back to the slide, ma'am. Yeah.
No, it is, don't go to the slides. I'm just
okay. Sorry. Yes, ma'am.
said benign. So it is suspicious for malignancy.
Yes, ma'am.
We have divided 4 into 3 more subdivisions, A, B, and C.
Okay.
A is mild suspicion of malignancy, B with 2 to 10% chance of malignancy. B, I'm sorry, I'm not asking a question, but I wanted to clarify this.
Okay.
Moderate suspicion, 10 to 50% chances of malignancy. And C is highly suspicious, 50 to 95% chances of malignancy. So 4 definitely needs a biopsy. Okay. 5 of course is malignant.
Yeah, it is malignant.
That area, where you just can't leave her, you have to biopsy it. Okay.
Okay, thank you.
Yeah, I think Anbu, ask her, ma.
Good presentation, Priyanka. Actually, all
Thank
three
you.
of you, fabulous presentations, very well done. Priyanka, I want to ask you, are there any Indian risk assessment models? Because the Gale model is a very complex model to use by clinicians. So have you researched, because there are Indian models available, and I don't think you mentioned that.
No, ma'am, I'm not aware of it.
So RCC Trivandrum has come up with something called the BRISK model, which is spelled as BRISK. It is actually formulated by a foundation called Snehita. So it's actually called the Snehita BRISK model, which utilizes data that, see, India is a breast cancer capital, actually. We are seeing so many breast cancer patients. And
even before the age mark also, even like youngest we saw in our hospital center was around 20 years. But because she was ignored, saying that usually at that age they don't kind of have awareness and this thing, she had already gone off to meds in the brain. So
exactly. So we can't use database models which are extrapolated from Western population, and these are easy to use models for our Indian patients.
Thank you.
Sundari,
ma'am.
Is there?
Yeah, there is. We've been very short in our question.
Not really, but yeah, ma'am, you can ask.
No, if it's not, it's okay.
Okay. Yeah. Thank you, ma'am. So thank you.
Thank you, ma'am.
Dr. Priyanka.
Thank you, Srimati ma'am, for all the pep talks you have had all this time, and thank you. I would like, I've taken the inputs from our oncologist, Dr. Suhas from Narayana Health Hospitals, and Dr. Girish from my own hospital, New Priyadashini Hospital in Mysore, and my close friend, Dr. Raghu, who was a radiologist. So I think all of them have poured all the inputs into this presentation, and I would like to my heartfelt gratitude towards that also.
Thank you. Thank you, Dr. Priyanka.
Okay, just one question again. Case of SB and CB in India.
Pardon, ma'am? I couldn't get.
Breast examination and clinical breast examination.
Yes, ma'am.
India, according to WHO.
Ma'am, according to WHO, 25 and above are recommended for clinical breast examination. But more than breast examination, it is the breast awareness that needs to be created among the women. So I think we need to more concentrate on explaining about the breast awareness and what to look for.
Yeah, that is for self-breast examination. Now,
Self-
the clinical is done by the physician,
Yes, ma'am.
gynecologist, but self-breast is done by the woman herself.
Woman herself, yeah.
It recommends that from the age of 20 years, more than anything else, like how you said, for awareness, so that they know how their breast feels. So
Yes.
and when is it done?
About 25 is
20,
it?
from 20. And
20.
what period of the cycle is it done? Immediately after the period.
Okay.
When the breast is least dense. Okay.
Yeah.
So,
Because before the
randomized,
cycles and I mean during the cycles, it's kind of sensitive. So she'll have the pain in the second half of the cycle. So, okay, ma'am. Yeah, thank you.
comments from
So there's a, I thought, ma'am, you're mentioning this because there's a randomized control trial from Tata Memorial, which has actually showed that cell breast exam reduces the mortality due to breast cancer.
does
Yeah.
isn't it?
Yeah,
Definitely.
there is an RCT from
You know
Tata
what?
Memorial published last.
ACS and all, that USPSTF, they all say no for breast examination, said both for SB and for CB. But in India, they don't come to us. So it's always
Yeah.
better that they at least do it for themselves so that they can come if there is a problem.
Ma'am, actually, now that the awareness is created, even if they have the lumpiness, they kind of come at least with a doubt. So when we examine, we can kind of explain it to them whether it's the dense breast or it's kind of any lesion which we have to further evaluate. So encouraging them for breast examination periodically would be ideal in Indian scenario.
Ma'am, there is a query, ma'am, about thermography. Thank you, Dr. Shantala. I think a query is from her. She wants to know because lots of corporate hospitals actually promote thermography now, not just for mass screening. As she said, mass screening, it's okay. So, what is the expert's take on thermography? Because lots of corporates have tied up with thermography.
I think even Karnataka Cancer Society is using it for mass screening. So how reliable and
Mass
sensitive
screening,
it
I
is?
think, is okay, but I think I'm more concerned about hospital-based screening with it. So, what is
Yes.
your take, ma'am?
Population
I
based.
think we had a meeting with the government some time back. There, even Kidwai director was there. He outright refused this thermography. He said
We
it's
don't use it
not
as
at all useful, he says. So they were there, even a thermography, there's people, representatives also were there, we were all there. But he said, no, it is of no use and we should not promote it, he says.
Okay.
What's your opinion, Anbu?
We don't use it, ma'am. None of the international organizations recommend it. I think it is not standardized because you can, if you look at people using it, these machines are not approved. I mean, I'm not saying everything in the market, but they don't run through an FDA approval or anything
Priyanka,
like
can
that.
you close your slides, ma, please?
Yeah. Oh, sorry, ma'am. Oh, sorry.
Slideshow, please
I didn't
end the
realize
slideshow.
I didn't recognize it.
Yeah, thank you.
Actually, the one more point to add for the thermal screening, when I asked my oncologist about it and I was discussing with him, he said because even inflammation can kind of give
Yes.
the heat
Give it a
sensation.
yeah.
So that false negative rate
Warmth.
is very high, and then he was telling that false positive rate is very high, and because of which he said it's not kind of recommended because there are many people even with inflammation who are coming back to him and they're unnecessarily subjected to mammogram even before the age of 40.
Thank you.
Thank you.
Leave it at
I
that.
will just take a minute to again introduce Hanbu.
Thank you. Thank you.
She was not there.
Thank you, ma'am. Thank you.
Thank you. Thank you to all the
You, all
speakers.
of you have done a good job, all three of you.
Thank you, ma'am. And congratulations to both Priyamvada and Dr. Shruti. You guys did a great job. Thank you.
So again, just take a minute to introduce Dr. Hanbu.
Thank you so much, all the judges and all the members who attended this program. Thank you so much.
Thank you. Thank you, Dr. Shruti.
I thank Srimati ma'am for all the support and guidance, ma'am. Actually, this is the first
Thank you. Thank you. Thank you.
Thank you.
So thank you all the speakers, and of course, again, I would like to thank Anbu for joining us, good friend of mine, and she's currently based in Coimbatore. She was initially with us in Bangalore, now moved to Coimbatore. So she is a great gynae oncologist, doing a great job in Coimbatore. She's got lots of accolades and awards to her credit. She's editor of Oncology, European Journal of Obs, Gynae and Reproductive Biology, Associate Editor of Indian Journal of Gynae Oncology, member representative of IRC, South Zone RCOG, test speaker, lots of publications, doing lots of clinical as well as academic work. So it's a great pleasure to have you with us, Anbu. So with that, I will.
Srimati, she is also a TEDx speaker.
Yes, ma'am. Speaker.
Just once, just recently.
So thank you, Anbu, for
I
joining.
didn't realize it was a big deal, but then I was asked to put it down as a big deal. So may I please share my
Yes,
slides?
yes. Thank you.
So this is a 20-minute talk on hereditary cancer syndromes. And for me, I feel like I will just be able to skim the surface, because if you look at an oncologist point of view, the last 10 years have resulted in a tremendous input as far as genetics and their implications in gynecological cancers are concerned. So it's going to be a very an eagle eye view, and I cannot talk about it in great detail for lack of time. But what I thought I would cover is our Indian perspective on breast ovarian cancer syndromes, because that's one of the things that we are really seeing an increased incidence in our population thanks to the obesity pandemic and increase in metabolic syndromes. I hope you are aware of the ICMR study that was just published in Lancet last month, which talked about the Indian diet and their implications on not just diabetes, but also associated metabolic syndromes. And I really urge you to read that. And I think that's also the reason behind the increased incidence of breast and endometrial cancers in young Indian patients. The second part, I will briefly cover about endometrial cancer. And when we talk about hereditary cancers, obviously, I think what we have in mind is the Lynch syndrome, because that's the main area of hereditary cancers in endometrial cancer syndrome. So talking about breast ovarian cancer, now the all ovarian cancer patients who are diagnosed, irrespective of their age and stage, except for mucinous type of ovarian cancers, have to undergo genetic testing. Now, this is the recommendation across all societies. So why is genetic testing in ovarian cancer being recommended? Because it has both therapeutic as well as prognostic value. And this, when we talk about genetic testing, automatically what comes to our mind, or what should come to our mind as clinicians, is BRCA1 and 2 pathogenic mutations. But we know now that there are entire spectra of genetic mutations that are associated downstream of BRCA mutations, and we have the capacity to test for these mutations as well in patients presenting with a diagnosis of ovarian cancer as well as breast cancer. Now, what are BRCA genes? I would like to call BRCA genes as the cleanup genes. Basically, these are genes that transcribe proteins that are involved in the repair of the double-stranded DNA breaks. So all of us can have double-stranded DNA breaks throughout our lifetime. And we have these two policemen standing around monitoring our double-stranded DNA, looking for breaks and jumping in to repair it. Now, all double-stranded DNA breaks can be repaired either of these three pathways. One is the homologous recombination pathway, which is the most important pathway, and it's the cleanest and the most efficient pathway. You also have error-prone non-homologous enjoining and single-stranded annealing pathways. Why we need to know these as clinicians is because if you have a mutation in BRCA gene, you can have problems in picking up. If you have a BRCA1 mutation, you have a problem in picking up these double-stranded breaks. And if you have a mutation in BRCA2, then the repair of these double-stranded breaks can be effected. So effectively, if you want to remember it very easily, you think of BRCA1 mutation as coming into examine and BRCA2 carrying in all the tools in her bag, trying to repair this. Now, homologous recombination pathway is downstream of these two guys. So they have an entire team of genes that they employ at different areas of these double-stranded breaks to make sure they happen. So you can have a problem in the leadership, which is BRCA1 or BRCA2, and you can have individual mutations in all of these different equipments that they use to repair these genes. So that team mutation is called as homologous recombination deficiency. So if homologous recombination deficiency happens, irrespective of whether there's a BRCA1 or 2 mutation, there can be accumulation of double-stranded breaks, and these double-stranded breaks can cause other chromosomal rearrangements that can accumulate over time, and that can result in a cancer. So this is the bird's eye view of what happens when someone carries a BRCA1, BRCA2 mutation, or a downstream homologous recombination deficient pathway. Because what happens is if the HRD pathway is not functioning well, is all the cell lines with 1 and 2 mutations will go into the error-prone NHEJ, or the non-homologous end joining, or the single-strand annealing pathway. And this also causes multiple genetic mutations to accumulate. And in a short while, in a younger age, the patient ends up having breast or ovarian cancer. Now, let's come to how common are these mutations. If you look at 10, 15 years back, we never tested anybody. Now, we are seeing so many patients turning up with mutations, and simply people are just saying we are over-testing, but maybe it is so, or maybe it is just really common in our population, right? If you look at international rates, this is supposed to occur in 1 in 300 to 1 in 500. This is an autosomal dominant mutation, which means that if mom has it, there's a 50% chance that her progeny, her son or daughter, can have it. And it is not just associated with breast and ovarian cancer, it's also associated with other sites, particularly pancreas, prostate in the males, and in melanomas. Now, what is the Indian scenario? I'd like to quote this study again from Tata Memorial. It's multicentric. It was done across India. It was published in JCO Global. And this looked at the prevalence of BRCA1 and 2 mutations among patients with ovarian or primary peritoneal or fallopian tube cancer in India. What it showed is that we are a high-risk population. There is a high incidence of germline BRCA1 and BRCA2 mutations in Indian patients with epithelial ovarian cancer, to the point that out of these 239 patients that were tested, it was BRCA1 mutation was detected in 15% of patients, and BRCA2 in about 6% of patients. Therefore, it is important for us to test patients more and more. We will come up with more mutations, but we will also have opportunities for therapeutic intervention. So who should undergo genetic testing in ovarian cancer? Unlike breast cancer, where we had these guidelines of if breast cancer occurs more than 50 years, or if multiple members have breast and ovarian cancer, then you test. It is now recommended for everyone who is diagnosed with a non-mucinous type of ovarian cancer. That is a level 1 recommendation, not just by European Society, but also by other American societies as well as Indian societies. Why it is recommended is, we talked about the point that it has prognostic and therapeutic value. But the important thing to remember about prognosis is that it has been shown that if someone is BRCA mutated as compared to a non-mutated ovarian cancer patient, they have a longer disease-free interval after primary chemotherapy. They have better overall survival. So straight away, you're giving them good news and bad news. In a way, you're telling them you've got a mutation, but you're also telling them because of that mutation, you potentially have a better overall and a disease-free survival as well. And in advanced stage, high-grade serous ovarian cancers, which are the most common type, 80% of ovarian cancers we see in clinical practice are high-grade serous. They present in advanced stage. They have very high mortality rates. In India, in a country which has different kinds of health setups, anywhere between 30 to 50% of patients may only live at at 5 years. So that is the high mortality rate that we see with advanced ovarian high-grade serous cancers. But even in them, if they carry a BRCA mutation, it is possible that they can have a longer progression-free survival if in this subgroup of patients. What is the therapeutic role? Now, this is what has happened in the last 10 years. Not just chemotherapy, we can now offer them targeted therapy. And the current recommendation is that if a patient at the point of diagnosis has BRCA mutation, along with giving them the recommended standard chemotherapy, which is paclitaxel with carboplatin, we complete their paclitaxel carboplatin either in the as a primary surgery followed by chemotherapy or neoadjuvant followed by interval debulking and then chemotherapy, and then we can put them on maintenance oral tablets for 3 to 5 years to keep them cancer free. Now, this was unheard of about 5 to 7 years ago. What is the targeted therapy that we are giving? We are giving something called as PARP inhibitors. The molecules that are available under this heading are olaparib, rucaparib, which is much cheaper, and also niraparib is available, and all of this is available in India. This can be used in first-line treatment. First-line treatment is when the patient is diagnosed for the first time, and then again in recurrent setting as well. How it acts is it inhibits a particular repair mechanism by this enzyme called PARP, which is polyadenosine ribonuclease protein in tumor cells harboring BRCA mutations. So there is this concept called synthetic lethality, where even if BRCA mutation is present, the cells can have single-strand DNA breaks being repaired by the PARP. When you add a molecule to negate the action of PARP, these two actions then combine together to kill the cancer cell. So this phenomenon is what is called as synthetic lethality. Let's look at what happens here. So you have olaparib. This was the first PARP inhibitor to undergo clinical development and receive accelerated approval in 2014, following which we've had a plethora of randomized trials which have evaluated PARP inhibitors and have reported improvement in PFS, which is progression-free survival and overall survival in various settings in BRCA mutated and other HR deficient ovarian cancers. The response rate, though, is highest with those who are platinum sensitive, which means that they respond very well to platinum chemotherapy and they don't have a recurrence within 6 to 12 months of after completion of chemotherapy. Then you have the platinum resistant patients and then platinum refractory patients. So actually in low-cost settings, platinum sensitivity is taken as a clinical indicator that this patient may have some sort of genetic mutation, and it is taken as a surrogate marker if the patient can't afford BRCA mutation testing. So they are now approved as first-line maintenance for all BRCA 1 and 2 mutated patients. They are also approved for use in relapse setting, regardless of BRCA status, because at that point in time, we are clutching at straws to help this patient to survive to 5 to 10 years. So whether it is a BRCA mutation positive or not, if the patient has a platinum sensitive relapse, that is if she relapsed 6 months after completion of treatment, then you can straight away give her second line chemotherapy and you can start her on PARP inhibitors, which is available as oral tablets in the dosage of 200 milligrams BD, and they continue taking it for a minimum of 2 years, and most patients do not have a recurrence in that time. It is also used in third line and beyond setting in BRCA 1 or 2 mutated patients. So what are the other implications of genetic testing? So you had one patient, she tested positive for BRCA mutation. After a diagnosis of ovarian cancer, you treated her, you put her on olaparib, and she's continuing to do well. But what else could you offer her? You have to remember that this is not just going to increase her risk of ovarian cancer, but it also has implications on her breast cancer risk. Therefore, you have to establish screening protocols for the index patient to detect breast cancer early. And like my previous speaker said, the difference between screening for a patient who is low or average risk and for a patient who is a BRCA mutated patient is the type of testing that we use. So for low or average risk, if you use a mammogram, for high risk patient, the recommendation is to use an MR mammogram, and that is done alternately with mammogram every 6 months for early detection of breast cancer. So assuming the patient we're talking about is previously detected with ovarian cancer, you start screening from the point of diagnosis. But if she is a family member, then you send her for genetic counseling. You make sure she undergoes the test after proper counseling and consent, and then you can plan risk reduction and surveillance for not just breast cancer, but for ovarian cancer as well. So it not just has implication for prognosis, for therapeutics for index patient, and for testing for breast cancer for the index patient. It has downstream benefits as well. So let me just go through a quick case example. This was a 33-year-old mother of two with a very uneventful medical history. Mom had ovarian cancer at age 50 years and expired at the age of 53. Grandmother had breast cancer. Mother was tested and she was carrier of a BRCA1 mutation, and therefore the doctor was counseled and testing was done. How do we get the testing done? We do a patient for a woman who is not a patient, who has just come forward for screening. We do a blood sample test. Some units do salivary test, but the most common is to just draw bloods and send it. So this detects germline mutation. Now, if you had the mum and her tumor was sent in, then you don't actually have a germline mutation report there. If tumor is tested, it is called a somatic BRCA mutation. And there are patients like that who do not carry it in their germline, but their tumor shows these mutations in each of those cells. The implication is that if she's only a somatic mutation carrier and she's not a germline carrier, then her family members are exempt from carrying the same mutation. Okay, so germline is for the genes that you carry. Somatic is for the way your body exhibits its tumor. So in this case, a blood sample needs to be sent because we are testing for the daughter. So you send it to a genetic lab for next generation sequencing. The turnaround time is 2 to 3 weeks, and the approximate cost now is come really low. It's about 10 to 30,000. It used to run in lakhs even just a few years ago. So this is the daughter's report. So she did test positive for BRCA1 mutation, and at this point in time, she was asymptomatic, and she was 31 years old, right? So what are the implications for her now for both prevention of breast and ovarian cancer in the future? And if she has any siblings, then you go ahead and test them. If she has any children who have crossed the age of 18, only an adult can give consent for genetic testing because it has implications on their health and their insurance. Therefore, you do not test young children less than 18 years of age. And so primarily, we're going to focus on prevention of her cancer risk in the future. The risk reducing strategy for breast cancer is, like ma'am mentioned, clinical breast examination. You start at 25 years. Some organizations actually recommend starting from 18 years, if that's possible, every 6 to 12 months, or 10 years before the youngest breast cancer diagnosis in the family. Annual screening MRI at age of 25 with the addition of alternating a mammogram added at the age of 30. And there is a concept of chemo prevention on whether you should add tamoxifen, but not many units give that. And there is also risk-reducing surgeries. There are a lot of women who opt for risk-reducing oophorectomies to reduce the risk of ovarian cancer, and some also opt for risk-reducing mastectomies because these are the two sites which BRCA mutations affect. So as far as screening for ovarian cancer is concerned, we do not have sensitive tests to pick up ovarian cancer early as yet. Therefore, the only tests we can offer, even if they are suboptimal, are CA125 and TVS. And it is done every 6 months that the woman presents to the clinician for her screening tests. Most guidelines recommend starting at 30 years of age, and then you carry on the testing every 6 to 12 months. When you opt for risk reduction through surgery, the RRSO is recommended at an earlier age compared to for BRCA1 mutation compared to BRCA2. Therefore, you would offer it at 35 to 40 years of age if the woman is a BRCA1 carrier, as in our case scenario, whereas you can postpone it to about 40 to 45 years if she is a BRCA2 carrier. And there is a lot of uptake of this following the Angelina Jolie effect after she got her double mastectomies and her oophorectomies and went on hormone replacement therapy. And we are seeing these patients quite commonly now as well. The other concept is to do a delayed risk-reducing salpingectomy followed by a delayed oophorectomy so that we can balance the risk of premature menopause that these women undergo, because they're going to lose their ovaries at 30, 35, 40 years of age. And sometimes the implications of that may be bigger than the implications of the breast cancer or ovarian cancer. So there is a large randomized trial that is happening in the UK as we speak, and we are expecting that this would come out as a recommendation soon. But having said that, the Canadian Society of Gynecologists, the SGO, recommends that we offer salpingectomies to all women, especially to women who are at high risk of ovarian or breast cancer, even if they are not BRCA mutated, to remove the tubes completely at any given opportunity, like, for example, sterilization or hysterectomies for benign disease. So I hope we remember that as a way of remembering that we can do something as generalists to reduce the risk of ovarian cancer for these patients. So to just recap the part about the HBOC, genetic testing is now offered to all women with ovarian cancer. And we are looking at BRCA 1 and 2 variants on the top, but we are looking at about 50 different genetic mutations under these two variants. And we are now able to offer it even in a tier 2 city like Coimbatore. So this is available for our patients for two reasons. One is that we can have implications for prognosis, and we have to remember that these are the better tumors, and we also have implications for therapy, and the molecule to remember is PARP inhibitors. It has implications for prevention of cancer in other sites, and it has implications downstream in other family members where testing and prevention can be offered. Srimati, do I have time for just this?
Ma'am, can we, ma'am, because 20 minutes is up, but can we just
Continue, Srimati.
Yes.
I'm sorry, ma'am. Can I continue? Because
Yeah.
I just try to compress it, but I'm very happy to stop here if that's okay.
Maybe just a
Continue.
bird's eye view, no, ma'am. We need
Continue,
it.
ma'am. Ambu.
Oh, can you say my slides?
Slideshow.
Right, sure. Yeah.
Okay. Continue as it is then, in case you're not able to do slideshow.
I'm not sure why I'm not able to share, but I'm not able to share now. So as far as endometrial cancer is concerned, it has now become the norm to test endometrial cancer patients for a genetic profile. And that includes testing for 4 different types of genes. One is over 4 different risk groups. One is the pole mutation, which is the good mutation group. You've got P53, which is the really bad bad prognosis group, and in between you've got the MSI or the microsatellite instability group. Now, pertaining to the topic that was given to me, this is the group that we need to focus on because these are the hereditary cancer groups. So tumor mutations or somatic mutations, such as I just expressed, can have all of these or any of these different mutations. Now, when we're talking about hereditary cancer mutations, if a tumor testing for MSI reveals a mutation in any of these 4 genes, which is MLH, MSH1 and 2, and PMS6, then what happens is you test the blood for these mutations, and then you can potentially pick up a Lynch syndrome. Lynch syndrome is a familial cancer syndrome that is associated with endometrial cancer and primarily colon cancer. And it's important for us as gynecologists to remember that endometrial cancer can sometimes be the first cancer that this woman presents with. And then following that, she may have colorectal cancer later on in her lifetime. So again, for endometrial cancer, now the recommendation is that all women need to have genetic analysis so that we can risk stratify according to the 2023 NCCN and ESCO-ESMO guideline. So the entire way in which we risk stratify these patients has shifted from histomorphological criteria to integration of histology as well as genetic cancers. Now, if you have a pole mutation, which is the rarest group, you don't need to give any further treatment because pole mutation positive patients, regardless of stage, do not recur and do have good prognosis. So in the order of testing, pole mutation is the one that needs to come on top. So in fact, some people do They don't test all four together. They do testing which is sequential. So they do the pole mutation first, and if that is positive, you don't even need to test for the others. But we don't do that. We just send everything together. But you can do sequential testing. So some units, some studies actually employed that. If you do pole and it's negative, then you go on and test for MSI, because the next that comes in. And if there is a positive test on microsatellite instability, which tests for the mismatch repair protein. So as the name implies, mismatch repair protein. So if there's a mismatch in the type of protein that is present in a particular DNA, this goes there and it repairs it. So if that repair is inhibited because of a mutation in your gene, then what happens is these genetic mutations accumulate and cancer ensues, right? So if you have something like that on the tumor tissue, then you go back and you test the blood for a genetic germline mutation. And if that test is positive, that's when Lynch syndrome ensues. Now, the third in the line is P53. Now, if these two are negative and you test P53 and it is found positive, it means that this is a high-risk variant of endometrial cancer. And this is probably the reason why many of us used to think endometrial cancer is one of those cancers, you do a hysterectomy and patients going to live long. But even in early stage 1A, well-differentiated, moderately differentiated cancer, sometimes we had this small subgroup of patients coming back with a recurrence in 6 months and 1 year, and then, having a full-fledged recurrence and dying off sometimes in a very short span. That was completely antithetical to the way we looked at endometrial cancers. Now, P53 mutation is probably the reason why even early stage, good prognosis endometrial cancers are recurring and having a bad outcome. So we want to pick up this 10 to 20% of early endometrial cancers with P53 so that we can identify these women, we can prognosticate and potentially add therapy. What therapy? Even if it is stage 1A, 1B, whatever, 2A, 2B, up to 2C, anybody who tests positive for P53, regardless of all the other histological features which we would have considered as low risk, we go ahead and give chemotherapy. We now have large-scale data to say that P53 positive early stage endometrioid type endometrial cancer patients benefit from giving chemotherapy. So many units are changing the way they treat these patients. So beyond, I mentioned up to stage 2, right? So beyond stage 2, stage 3, that means that lymph nodes are positive. Automatically, P53, you're not too bothered about it because this is advanced stage. So you go ahead and give chemotherapy there anyway. So as far as testing is concerned, stages 1 and 2, there is a remarkable change. Anybody with stage 1 and 2 pole mutation, no treatment. Anybody with stage 1 and 2 P53, then you can give chemotherapy. Now, 1 and 2 with microsatellite instability, there is again another molecule that we can use, which comes under immunotherapy, and that molecule is called pembrolizumab. This is a checkpoint inhibitor. There are now trials called Keynote trials. Several variations of Keynote trials have come in different areas. One is colorectal cancer and endometrial cancer, which shows that addition of pembrolizumab in the upfront setting, in the maintenance setting, can actually extend the survival of these patients, especially if they are advanced stage disease. So now it is recommendation across the board that if you have a microsatellite instability and if you have advanced endometrial cancers, you have to go ahead and treat them not just with chemotherapy, but also add on immunotherapy. Some units are just moving completely to only immunotherapy. Now, this is for an endometrial cancer patient. Now, what happens if I detect a Lynch syndrome, which I have never done till now, because it is quite rare, only about 5 to, unlike breast cancer, BRCA mutations, 5 to 10% of endometrial cancer patients end up having, an MSI, and then we go on to pick up Lynch syndromes very rarely. So, but if they do, then they can get screened for colon cancer. The way to do it now is a CT colonoscopy. And if their family members can get tested, all adult male and female relatives of the primary patient can get screened for endometrial cancer. As far as we are concerned, what is actually recommended is to do a transvaginal sonography. Look at the endometrial thickness, also look at the ovaries, because about 10% of patients can have an increased risk of ovarian cancer as well. And you might want to do a hysteroscopy and an endometrial sampling if you feel that the endometrium is thickened. There is also risk reducing hysterectomies with BSO that is recommended around the age of 35 years to 40 years. For colon, there is not much you can do in terms of surgery. You just screen them. But what is the most important thing that has been found out for risk reduction is aspirin. There has been a lot of data that is coming up on the preventive role of aspirin. When it is taken for just 5 years, it reduces, of course, you'll go on taking it, but when you look at risk reduction over a period of 8 to 10 years, the risk to reduction is about 25 to 30% for women, for patients who have been found positive for Lynch syndrome. So that is hugely exciting. So we have a very simple molecule called aspirin. Day in and day out, we use it for our preeclampsia prevention and so on and so forth. Now that is coming up in a big way. So we do have something to offer them. We just don't test them and leave them off. We can put them on aspirin if they are found to be positive for Lynch syndrome. Yeah, thank you. With that, I'll end my lecture.
Thank you, Anvu.
It was an excellent talk, Anvu.
Thank you, ma'am. Sorry, I don't know why my slides couldn't be shared properly though.
We still haven't recovered from the onslaught of information.
Yes.
That was so good, very good, really. I wanted to know, in case
Yes.
you have a patient with endometrial cancer, you still have to do a somatic line mutation and a germline mutation, or only a...
So straight away it is only somatic. So what is the somatic tissue that we are sending is you can send the endometrial biopsy itself now. So we don't do that yet because for us at that point, we don't even know if the patient is affording enough to come back to us for surgery. So we are still doing the hysterectomy and then sending the patient for the tumor tissue there for testing so that we can risk stratify post-operatively to determine whether they are low, medium, or high risk. But many units abroad are now sending the endometrial pipple sample itself for risk stratification, and the implication is on staging. Now, potentially for pole mutation, if you detect it, say about 5 to 10% of patients will turn up to be pole. You may just have to do a hysterectomy. You don't need to probably stage. The problem is that we still do not have a guideline to say that if it is pole mutation, then you don't need to stage. But I think it will come up in the future. The advantage is that you're avoiding the entire spectrum of lymphadenectomies and its complications. Now, if you have MSI, say, for example, you may want to remove the ovaries without preserving ovaries for a younger person because now there's a lot of conversation about preservation of normal looking ovaries in a premenopausal woman to prevent premature menopause. Now, the implication is also in the fertility sparing group. So we are seeing young endometrial cancer patients who are detected following infertility workup prior to IVF when an endometrial biopsy reveals malignancy. Now, if this patient had an MSI on her tumor tissue, potentially she may not respond very well to your hormonal therapy, although right now we will not deny her hormonal therapy. And second thing you want to know is whether the ovaries are also carrying those mutations and what happens to the progeny if the baby turns out to be a carrier. So that implication is that P53, you'll go all out. You'd stage her, you remove the paraiotic nodes, make sure there's not much chance for recurrence, and you'll go on the completely other end being very aggressive. Now, the implication for germline testing is only in this one group, which has the potential to have Lynch syndrome, and that is the subgroup of patient that test positive for MSI. You don't need to do blood tests for any other group. So all of the other tests are done only on the tumor tissue, which is equivalent to somatic testing. Blood test is equivalent to germline mutation, and that is only Lynch syndrome.
See, it makes a very big difference if we could test the tissue which we take by pipelle sampling for these mutations. You know why? So many of our patients have endometrial cancer at a young age and they wouldn't have conceived yet. So we can please guide them, tell them that.
Especially in your setting, ma'am, because you treat so many of these patients, especially in your...
So you feel bad for them because we didn't have much to offer a few years back, except
That's
for
true.
images.
Yes, ma'am.
Now, once we do this, we know where they stand and we can advise them accordingly. If they
Accordingly. Yeah. Yeah.
have only pole mutation, they can happily go ahead and have a baby too.
Yeah, precisely. Or maybe you want to think about surrogacy or offer something else which is safe for the woman without unnecessarily putting her through that 1 year of hormonal therapy. Yeah.
Beautiful, excellent. Any Sundari, any comments? Sundari? She's dumbstruck.
Yeah,
No, no,
we are
no.
all
Please.
we
You're
are
so
all
kind.
completely thanks, Anbu. That was really excellent. Thanks a lot.
I'm
Thank
so
you.
happy
Thanks so much.
that
I
we
just wish more people were here to get benefited. Anyway, it's going to be on YouTube, but I would have,
that is the disadvantage, Srimati. They'll
yes,
just go to YouTube and listen whenever they have the time.
yeah,
Thank you.
yeah.
Thank you for. It
Thanks.
is always a pleasure to see your faces because I'm still very much a Bangalore Hudigi and my heart belongs there. So it's so lovely to meet my teachers.
First
And
name which we thought of was yours.
thank you, ma'am. I know you always say that, whether it is for Kasoga, whether it is for the teaching programs. Thank you so much. Hi, Shobha, ma'am.
Hi,
Shobha, ma'am.
Anbu. That
Such a
was
pleasure to
lovely.
see you. Thank you, ma'am. Thank you
Unfortunately,
so much.
fortunately also, yours was the only lecture which I could attend properly. All the
I'm so
others,
glad.
and all the others I could not. I was in some other meeting, and I'm very glad that I did, Anbu, because
Thank you,
there's a
ma'am.
lot of clarity in the
Thank you, ma'am.
information you give, and I think we have a lot of doubts in this field about
Thank you,
tumor
ma'am.
markers or about
Mm.
testing, genetic testing for cancer predisposition, etc. And I am sure that people have really, the audience who logged in have really more clarity to now. And I think it's an ongoing learning, Anbu. And I
Yes, ma'am.
wish that we will be able to invite you more often. And certainly that is on the cards. And
Thank you, ma'am.
also, you are also a Bangalore Hudgi, and we also take a lot of pride in your growth because
Thank you, ma'am.
I think you're one of the upcoming oncologists, and we are really keen to see you grow
Thank
strength
you,
to
ma'am.
strength. So, all the very best. Thank you
Thank you,
for
ma'am.
being
Thank you so
here.
much.
Yeah, thank you.
Appreciate it.
We'll
Yeah.
be teaching you again, Anbu. Okay, be prepared.
Ma'am? Yeah, please disturb me. No problem. Thanks, Srimati, for the opportunity.
Thanks, Anbu.
Shobha
Yeah.
Bembalgi was there. Is she still
Yes,
there?
ma'am.
I'm not sure.
She's
Shobha,
not.
are you there, Shobha?
I can't see the name, ma'am.
Hmm.
Shall I do the vote of
Yeah,
thanks?
please.
Yeah,
No, she's left. She was there,
Yes,
but
ma'am. In the beginning, she was there.
yeah. Srimati, vote of thanks,
Yes,
Kodbidamma.
ma'am. So it's always a great a pleasure to have an expert coming and giving us great insights. And this was one of the excellent sessions. So we have to really thank our expert as well as the judge, Dr. Anbu Subayan, who, despite the rains, despite a busy schedule, coming and
it's just more than rain, it's the traffic jams,
traffics, yeah.
which
So, and then untimely as well, untimely rain. So, thank you, Anbu, for giving an excellent insight into the hereditary aspects of ovarian, breast, and of course, endometrial cancer. So, we also thank the three speakers, Dr. Priyamvada, Dr. Shruti, and Dr. Priyanka, who did a great job. Of course, our series judge, Sundari ma'am, who has been the backbone, and Jyotika ma'am, without whom I couldn't do any of these webinar series. I'm really indebted to you for hand-holding me at every step. Of course, we have missed Durga Das sir today because of his other
Srimati
commitments.
doesn't
Yeah.
need help at all. So don't believe her.
Ma'am, please. Yeah, everybody knows, ma'am. Even if we don't say, the truth is there, even if you deny. So it is there for everybody to see. So, and Durga Das sir for having given us this opportunity. Of course, he is sorely missed today. Shobha ma'am for joining us despite a busy schedule, and all the delegates. We wish we had more delegates participating, but all the delegates who participated, Arun for the backbone support which you have given. So thank you very much. And next month, we are not having a webinar series. Our next webinar will be in December. We look forward to meeting you all in Kosoga at Tumkur. And again, I mean, I can't express my thanks enough to you, Anbu. It was an excellent
Thank you so much,
session. Yeah,
Srimati.
excellent
Please, not
session.
needed.
So-
Thanks. It's my pleasure. It's my pleasure. Thank you.
Yeah. So thank you. I think I did not log in earlier.